Hello, welcome to Brain Club, the podcast, a space for learning, unlearning, and reimagining new ways of being together in neuroinclusive community. I'm Dr. Mel Hauser, Executive Director of All Brains Belong Vermont. Welcome to our brand new podcast. Brain Club is All Brains' full weekly community education program where we demonstrate our approach to neuroinclusive culture through community panels, guest speakers, and book chats. It's a place where we shift broader community awareness about the issues of concern and importance to neurodivergent people in our community and promote new ways of thinking and being in community together. It's a place where we transform culture by modeling what's possible with the idea that then you go out into the rest of your lives and carry it forward. You can already access all the recordings from our website at allbrainsbelong.org, but our community asked us to turn it into a podcast, so here we are. These conversations are not medical advice and they're not support groups. They're an invitation to think differently about health, connection, and how we build systems that include everyone. Each episode features community panelists sharing perspectives and lived experiences. We hope you'll listen with curiosity and reflect on what it brings up for your own life. In this episode, we hear from 3 primary care clinicians about what often goes unsaid in healthcare, that the healthcare system is failing both patients and doctors. From time pressure and burnout and conflicting access needs, we talk about how misunderstandings between clinicians and patients are often symptoms of deeper structural breakdown. This conversation is about what it means to stay human inside a system that makes that hard for everyone. I'm joined by my colleagues, Dr. Gabe Worzella, family physician, and Sierra Miller, family nurse practitioner.
When we launched All Brains Belong, not only was it really clear to us that we needed to do anything for the neurodivergent community, we have to do everything, that it's not just medical care, we're also looking at employment and education and social connection, but even within the medical care bucket, there is a lot of unlearning and reimagining that has had to go into this. And what we have learned the most from is our patients in building this community village of learning and healing together. That is where the most successful reimagining has come from that. What we're about to do before I launch into this conversation between me and my colleagues, Sierra Miller and Gabe Worzella, we recorded an interview about our experiences navigating this, doing the unlearning and reimagining. What I'm going to just put forth is that we're intending this conversation to be addressing the double empathy problem. If you've not heard that expression before, that's a term coined by Dr. Damian Milton, who is an autistic social scientist in the UK, who found through research that it is not that there is one set of normal social skills. It is that when there is a mismatch between neurotype, between autistic versus not autistic, that mismatch of worldview, mismatch of communication style, that is where communication breakdowns happen. So there, the double empathy problem can be thought of in so many different ways. And I think as it relates to the healthcare system, we're trying to bridge the double empathy problem between, what we know about neurodivergent health and what we know about being trained, having practiced for a long time in the traditional healthcare system. Because I think that it's a mismatch, it's miscommunication between healthcare providers and patients so often because of the mismatch in communication styles and content.
Here we go.
I think we should share with our audience that, not all our patients are neurodivergent, and certainly not all our patients I would identify as being neurodivergent, and they come because their needs were not met by the traditional healthcare system. That's what they have in common. That's what they all have in common. And amongst that group, the overwhelming majority of our patients have this pattern, right, of neuroimmune conditions.
I think they most often talk about not feeling listened to or heard. And I know that's kind of a vague thing, but I think feeling like they're having their symptoms dismissed, whether that's because, oh, you're young and no, you can't be in that much pain, you can't have this thing, or oh, this disorder is so rare you couldn't have it.
I was talking to another provider about, neurodivergent healthcare and how some medical conditions tend to coexist, and that there's like actual literature and papers out there about it. And this is someone who's probably like 5 to 10 years my senior. Like they've been in practice that much longer than me, and they had no idea. They're
Right.
like, I didn't know that, these things happen together. And so I think the issue is that these things are not on people's radar because it's not being taught in school.
Right. So let's start there. So what do you remember, if anything, about what you were taught about autism and ADHD?
Nothing. I had no idea they could coexist.
Yeah. I was never taught that they could coexist,
Yeah.
despite
Yeah.
they almost like they coexist more often than they don't.
Right.
Yeah. I feel like for me, autism education was like developmental milestones and MChat and that type of stuff for kids. And then ADHD was this happens in kids and we use stimulants to treat it.
Yeah, they
That,
were
like-
they were separate.
I was not taught that autistic physiology was different than non-autistic people's physiology. Like I was taught, the deficit-based paradigm of like, here are the things that are wrong, and we call this autism. In kids, there's never a discussion about autistic adults. I don't think that I had any ideas about autistic adults, despite being one and not knowing. But like it was just never on the radar that like there were autistic adults, let alone the medical conditions that people have. So like when the list of all the co-occurring conditions, these are all things that kids had. It was very strongly implied, if not explicitly taught to me, that it was like patient blaming. Like you have gastrointestinal things because you only eat chicken nuggets and pasta and you don't exercise. So that's why you're constipated. Like, not that you have stretchy colons that get all stretched out.
Right. Increased periodontal disease because of not doing oral hygiene.
Right.
And this is more systemic, right, in the healthcare system, but the zoomed in style of teaching, like, there's psychiatry and there's gastroenterology and there are all these things that are separated, but in reality there are so many things that are interconnected that it's silly that we're not taught more of a like zoomed out picture. This is like an entire being that has multiple systems that actually work together and rely on each other and are influenced by like how your DNA is being transcribed. And it's unfortunate that more of that zoomed out approach to teaching medicine isn't taught, because it results in the zoomed in, like looking at these two things that you already know coexist and not seeing the bigger connections with some of these other things, and how that impacts people in the healthcare system, impacts patients in particular.
Yes. And I think that what you said is really interesting, because I think that I would describe my medical education as being very top down. An autistic patient is more likely to have X, Y, and Z list of conditions. Top down, you memorize the associations and they're tested on board exams. But that's not how the patient comes in. The patient comes in bottom up. And in a healthcare system that is so fragmented, like you said, the pattern is not created in a zoomed out enough approach. The pattern is created with way too, and even people with the type of brains that are really good at pattern matching, the whole picture of the pattern was not taught because it's not known. And one of the reasons these patients are thought to be rare, right? So if what's described is that 2% of adults are autistic, I mean, there's zero chance that that's true. It would need to be more than that. But anyway, it's thought to be it's thought to be rare. So why would medical education be structured on this entity that is rare? Because what's missed is that the neuroimmune conditions that are more common in autistic and ADHD people are connected to the things that are known to be very common. So, when we think about, like, in our practice, right, how we see a lot of mast cell dysfunction, and guess what? That's connected to diabetes and hypertension and, like, all the things, right? So
right, and IBS and mood, anxiety,
migraine. I mean,
migraines.
It's connected to everything, but yet,
Yeah,
not zoomed out enough.
I think that's what primes primary care providers for doing this type of work, is because theoretically they're the ones who are already doing that kind of like look at the full body and the full patient, and they're the ones who are seeing all the different things that are going on and know the patient longitudinally enough to theoretically be able to see the connection between everything.
But what I would say is that even though we have a population of clinicians who are ideally poised to spot the pattern, we have a medical system, a healthcare system that is thwarting primary care clinicians to have full access to their cortex, right? Like, so we have this healthcare system that is forcing primary care clinicians to see, a patient every 10 minutes, 10, 15 minutes.
Most practices are 15-minute visits for follow-ups, 30-minute visits for new patients, or, wellness exams or whatever. And on top of that, you're managing an electronic medical record system and paperwork and interpersonal work stuff. It's like you have 5 or 10 jobs within one job already. And so I don't want to, the blame is the system. I don't think that people go into medicine intentionally wanting to dismiss people at all, but it's something that ends up happening. You're exhausted, you're tired, you didn't eat breakfast, you didn't have time to eat lunch, and then you lose, what's it called? You get dysregulated. There's a line that happens, and you're like backed up against a wall and feel like in some ways it may be the provider kind of advocating for their own access needs by saying, okay, we don't have time to talk about this today, but not knowing that's how that makes someone feel.
You don't have the cognitive resources to do what needs doing in that moment because the system is thwarting you. And so you don't have the ability in that moment to zoom out, because that's an executive function. It's like a higher order brain skill to zoom out, to self-monitor, to know like what you're saying, how you're saying, your tone, your body language, all of this stuff. And I think that there's a lot of, really inadvertent communication breakdowns that
unintentional dismissiveness.
Yeah. I think like what I hear a lot, like when we have new patients, the overwhelming majority of our patients have this pattern, right, of neuroimmune conditions, that there is physiology that explains these multi-organ system symptoms. People show up and they have like this laundry list of diagnoses, and like, why would it make sense that a human being would have like 40 things wrong with them? Turns out, their connective tissue is different. It's just a different way of being wired. And it just so happens that these physical health conditions, which, are exacerbated by dysregulation. And when your access needs are thwarted by like, all of the systems, this actually drives like a worsening of neuroimmune conditions. But people don't know that. Nobody knows that. Yeah. They just like feel broken, and they're told that they are broken, and then they're like shamed for seeking help. So like, anyway, shamed for seeking help, shamed for seeking help in the way that you authentically communicate when you seek help, and shamed for not complying with recommendations that don't work for your brain.
Right.
when we hear their story, they can trace this back for like decades, right? Like decades.
Yeah.
And it's about having the opportunity to share your story in the way that works for you. So some people need to info dump their story with mouth words. Some people need to
Bring a list.
Yeah, right. They're the patient with the list, right? The one that's like shamed and othered by the healthcare system. They wrote that list, and that list is incredibly important because it has all the information in it. Like, anyway, there's some people like, we have a patient who I'll never forget, new patient visit, brought a mind map that showed me like, all the things that like, this makes it worse, this makes it better. And I'm like, I know that pattern, right? So like you get the patient's information in like their, so say like in their native tongue, like in the way that they best communicate, you get a ton more information. But the system thwarts patients from communicating.
I think the other thing that I often see, especially with kids coming in with neurodivergent kids, especially, is just that they have not been able to access care in other settings just due to the like sensory overload of the specific setting. And so, whether it's like providers not knowing their sensory needs beforehand, before actually coming into the visit, or like just before walking into the room, whether it's like the fluorescent lights, whether it's thinking that they're going to need a vaccine the entire visit and being anxious and not interacting the entire visit until they know they don't need one at the end. And that's why I like having the like information before a visit of what somebody needs, what their sensory needs are, because starting off the visit that way makes such a huge difference. And if we didn't have that, I wouldn't know necessarily.
Well, you left something out. How do we have that information? We asked, right? Like that's the thing, right? So if you ask people what makes them comfortable, and you ask and you try to do those things, they usually have a better healthcare experience.
Right. Yeah. I mean, it's just the systems within the systems already have like there's their standard expectation. Like, this is how you communicate, this is how you take information. Like, people teach you how to take notes. Like when you're in school, here's how you study something without ever knowing how your brain works. Like, and then you try to fit yourself and mold your brain and your whole way of being into the box that who knows who designed it, but the box that has become like the standard expectation of how to communicate, how to interact, how to socialize, how to just exist, how to be within the workplace. And it's suffocating.
Yeah. I mean, I remember even like as a pre-med student, like, my volunteer gigs or like some of my jobs after college before medical school, like it was just so clear that there was judgment going on, and that what you just said, like, that there's one right way to do the thing. It was just so clear that it was not okay to show up as one's true self, not just as a professional, like as a patient. Like, I remember being like a young 20-something, and I remember being like, I have to do something. I have to do something to make sure they don't think I'm weird or that I'm like melodramatic or that, anyway, I have all the things. I've always had all the things. As a patient, I've never had care for my all the things, because I never tell anyone my all the things, because that's a surefire word to get judged.
Yes. Not because it's funny. It's one of those. It's just act in this way, communicate in this way, or you will go unheard.
Yes.
Like you have to communicate a certain way, or you won't be heard. And not everybody can make that adjustment. And so those are the people that are staying away from healthcare because it's overwhelming or confusing or uncomfortable or unsafe to.
Yeah.
I feel like I see that so commonly. Like if I'm talking to somebody about like being in a pre-diabetic range, and before I even say anything, they start with, but I eat well and I've been struggling with my weight in my entire life, and like preface it with like, I'm doing all the things. Please don't blame it on me being at fault or blame it on my weight. And it's just so ingrained in patients to kind of preface a visit with, these are all the things that I'm doing, because otherwise it's so common for it to, because that's how we learn. We learn that diabetes is lifestyle factor related, and that's the only thing, versus inflammation and genetics and all the other things
And
that
mast cells.
contribute to it. Right. And that like weight isn't always totally changeable.
It's also that, like, I mean, this is such a bigger picture. Like, so not only is there a right way to be a person, but like the message that there's a right way to be healthy too. And like, so, when you think about like all of the anti-fat bias and shaming that goes on in the healthcare system, I mean, it starts in childhood. I mean, it's so bad.
Yeah, I think shame is unfortunately one of those things that is, I don't even know why either, taught from the very beginning, as children.
I wish that it were normalized to say when you don't know. Instead, what is modeled, or what was modeled for me as a trainee, is that you fake it till you make it, and that when someone says a thing that doesn't match your worldview, you quackify them. Well, that's not a thing.
I remember hearing in medical school, and thankfully I had a nutritional biochemistry background, so they said that taking vitamins is just paying for really expensive pee. And I was like, they were like, well, why would they say that? Because they stopped taking the vitamins because they felt guilty and shame. And I was like, because they don't know biochemistry. They don't understand that nutritional needs of different humans are just as different as the brains that are operating. So instead of saying, I don't really understand how the human cell and mitochondria and all of these different vitamins and minerals interact, so I'm going to say that taking vitamins is stupid. You can get enough from what you eat. And then I'm going to teach that to people that are training under me, who are then going to say these things to patients, and we all just don't know what we're talking about.
Yep. I remember being taught that people, quote, outgrow ADHD. Kids outgrow ADHD. And, I believed that. I was taught it, despite being, an undiagnosed ADHDer. Like, anyway, that kind of mythology is just so widely held. It's the same way, like, I remember as a trainee, the patient with the list. And, like, I thought that was awesome, because I'm a visual processor and I wanted to read the list. But anyway, that person gets shamed. But also, like, the patient that comes in and says, I read about this on, WebMD or some other website, and like, I read this article, and I want you to, like, how does this fit into my, like, I don't know, I just always thought that was awesome, because they were engaged in their health. And anyway, it's not that hard to be like, I don't know about this. Thanks for the article. I'll read it and we can talk about it again next time. It's not that hard, but that's not modeled. The opposite of that is modeled. But like in the context of what we talked about before, where the system is like, you must see the patient every 10 to 15 minutes. Like, so now I have something else to do.
Right.
So
it's unfortunately, I think within the medical community, it's learned behavior. And learned behavior from maybe, someone else's teachings that the list is bad and those patients are complicated, and the eye rolling and all that kind of stuff. It's learned. We weren't taught how to really manage that, as a, well, just see them more often.
Right.
Wow. Okay.
Right.
It's that easy.
It is that easy.
And I think, like, coming back to the, like, not feeling comfortable saying you don't know things, like, there's this expectation that a healthcare provider knows everything about every single body system, and that's not feasible for anybody, I think. I mean, I certainly don't know everything about every body system.
like primary care is really hard. And
Right. Yeah.
primary care is really hard. There's so much to know. There's so much to spot. You're on the front lines, and then you have the system thwarting your ability to do what you're trying to do for your patients. You don't have full access to your cortex, and you're trying to survive, and like it feels a lot like treading water and like trying to survive and trying to do everything you can for your patients. There's just, it's so much.
Yeah. And I think for those in traditional primary care practices, whether you're hospital owned or private, I mean, what's normalized is the dysfunction of the system. It's like, yep, this is just the way it is. So, you know, so that's what we have to do. So we're just going to keep doing it. And just felt like there has to be a better way to do this, but like everyone's stuck.
It's a failure of imagination, right? So like what we do all day, I mean, the only reason we're really able to do it is because we don't have a bureaucracy. Like the patients need a thing, and we kind of like try to figure out how to do that thing. And like a systems get dysfunctional. I mean, like I think individual providers are most frequently operating in systems where they don't have autonomy or agency to do a lot of things. Like when I do trainings and services for healthcare practices, or even like at, you know, conferences, like people are like, oh yeah, that's really great that you can do that thing in your special setting. But like, you know, us people in the trenches, you know, what about us? It'd be good to wrap up maybe talking about like, what are some things, not just like, you know, what are the medical conditions we manage and how do we manage them, but like, what are some things we do that are free to do that are different than in other settings? Because I think that one of the things that we do is I think we teach patients that they are the experts in their own bodies. Many of them don't know that. This is like new information that they're getting. That lens is really a requirement for trusting your intuition, for connecting all the dots, for learning about your access needs and naming it when they're not met. If you don't think that you're the expert in your own self, because you got messages to the contrary your whole life, it's huge.
Yeah. Yeah, that's definitely makes a big difference. I think as a practice, us, you know, before patients even come in, we're asking them, before they even become our patient, they know that we care about how they learn information, how they would like visits to go.
Giving people choices of sensory needs and ways to access care, and a lot of those are free, like turning off the fluorescent lights in an office, or letting people bring fidgets and whatever they want with them, and making that explicit that like you can bring whatever you want with you, having things in the office for people to be able to write their own notes so they don't have to bring their own things.
I think we often get feedback, right, that patients have never been asked for what they need.
But the fact that we asked means that we care, and that makes
Right.
that patient that much more comfortable to share things in their like authentic, unique way.
Right. And the fact that, you know, like you said before, Gabe, about how, you know, we were trained to ask questions a certain way. Like, guess what? There are some brains who can't answer questions in the way that they're being asked in that default way. And so, like, just the idea of, you know, open-ended questions do not work for all brains. And the idea of providing people with a menu for examples of, like, these are things we offer all people with all types of brains, and you can let us know if any of these things would be helpful to you. And it's not because you have, you know, an issue, you don't have a sensory issue or a communication issue. It's that you would just find these things helpful to have available to you. That's all. The other thing that I think that I've learned in this past year and a half is that, like, about just the idea of healthcare as community. And I think that has really, really stayed with me, because I think that's one of the key things that we're doing. I mean, it's not for everybody. That's why we try to be really transparent about the model here, and, you know, have people not join, not come when they're not looking for this model. But I remember at my old practice in a traditional setting, I remember meeting with people back to back who had no friends, totally socially isolated, and it was like they actually like loved the same things, and like the healthcare system says that you know, HIPAA, you know, you can't do anyway, but like turns out like they can introduce themselves to one another if you build a forum that they would both come to. Like, think about how much we have learned from patients, like coming as this village. Like when we think about all these really complicated medical conditions that most of the healthcare system doesn't understand, when you bring patients together and you give people an opportunity to describe in their own ways what their experience is like and what helps and does not help, people feel alone. They feel just alone in their lives. And once they know that they're not, there's so much healing in that. Hey. Ah.
So that concludes our panel. Let's take some questions and comments from the audience.
I would love to hear any responses or reactions or thoughts that anyone would like to share. Amy.
Well, I just want to say thank you to the three of you, because, you know, obviously I am a medical patient of ABB, and, you know, I'm always on the other side of just receiving the information from the three of you. And I just thought it was incredibly generous of all of you to kind of share the vulnerabilities of, you know, having this education, having this training, and then sort of moving outside of that model, and the risk, you know, even professionally, that you're taking to like care for all of us. And that really, it's like been such a huge result for me, having, you know, basically I haven't had healthcare until now. And so I just felt like it was incredibly generous of the three of you to share your experience. And yeah, I really honor all three of you for who you are, what you're doing. And if the medical system is willing to like even come in and see what you're offering, I think that they would be really blown away for the results that you're getting. So thanks so much.
Thank you, Amy. Thank you so much. You know, I wouldn't have had language to describe this when I was in my old life. It was not until it's like the ability to zoom out and, you know, understand nervous system regulation. Like when we say like the rest of the healthcare system, it's like the difference between the healthcare system and the people in it. I think the people in it, for the most part, like really well-intentioned and often really quite dysregulated by the healthcare system. And I think until, I mean, it's like when you think about I mean, medicine's not the only profession where, you know, burnout, you know, the epidemic of burnout, it's when the system thwarts your access needs from being met, and you don't even know that you don't even know what an access need is, let alone what yours are, and that it's like what you do for a living that thwarts you. Like that sucks a lot. And so it, you know, I can only speak for myself in that as an autistic person belonging to autistic community and like trying to do it differently within this community village model, like I really can't imagine any other way to practice medicine now that I've lived it. Because I think it's like, when you think about, just even having transparent conversations about access needs, like I'm not gonna put you on the spot. I'm not gonna put anybody on the spot, but like, sometimes it kind of sucks to be a patient here. We don't answer the phone, it's because we don't have the kind of brains that can answer the phone and see patients at the same time. And we tell you that, and like, we're just kind of modeling, like, what would it be like to be in a community, in relationship with other people, where you transparently showed up the best you can and made it okay for everyone to show up the best they can. And there's a lot of unlearning that would have to happen for a lot of people, because specifically how medical education teaches not that.
I don't want to say what other people's experiences are, but my experience is like, if I text, it's like somebody in the team, whether it's like Lizzie or Olivia, like, it's just like the way that you created this, I feel cared by, by everybody. And so if I am to text, I do feel like I get an answer, whether that's like a prescription med or an upcoming appointment. And it's like, it does feel like the team of people know me or are getting to know me more. And so it feels better because I don't actually want to make a call. I'd rather have to send a text.
That's awesome. Sarah.
One of the things you're making me think of is kind of the cost of this emphasis on professionalism. And because the emphasis on professionalism seems like what you're getting people to do is to identify first with a profession and first with other professionals and with the profession that employs you. And that's in contrast. And so now you can't show up as you have to show up as this expert. And that's very different than healthcare as community. And so it really prevents you from showing up as a person.
It's really about reflecting on what goes into a healthcare relationship, and like maybe rethinking a lot of the things that medical education truly explicitly teaches that often interferes with relationships. Sierra.
Yeah, I think just on that point, Sarah, I think that it's so common in that like zone of professionalism to teach people to hide certain things about themselves. I mean, I was definitely taught in school specifically to like not tell patients. And I think that's why a lot of healthcare providers who are neurodivergent aren't disclosing that to their employers, not disclosing that to their coworkers, and definitely not disclosing that to patients, because it's viewed as such a liability. And that means we have less representation. That means we can't connect with people as much.
Like, if you are explicitly taught, hide your true self, like, how often does some form of disclosure or just like some sort of sharing of something about one's authentic self is what cues safety for a lot of our patients?
The healthcare system sets patients and clinicians up for breakdown. It creates pressure, erases difference, and leaves little room for anyone to be fully human. But when clinicians name what's not working and stay curious, something shifts. We are so grateful to Gabe and Sierra for joining us in this important, essential conversation, for speaking from inside the system and offering a glimpse of what care can feel like when the relationship between clinician and patient is centered. If you want to keep exploring with us, you can join our live Brain Club events most Tuesdays at 6 p.m. Eastern. You can also dig into our free digital resource library with all the recordings from the past 4 years at allbrainsbelong.org. You're not alone, and we're glad you're here. See you next time.